Welcome, everyone. This is Asa Carter. I am the Senior Manager for Education and Training for ACS Cancer Programs, and I'm very glad you could join us today for our webinar titled Breaking Barriers, Year 2 Interventions and Navigation. Before I turn this over to our moderator for today, let me go through a few logistics. As you heard from the announcement, all participants are muted during the webinar, and we're asking you to submit your questions to the question pane that you'll find on your control panel. And that should include any questions about the webinar content that you want the speakers to address, but also any technical issues that you're having, such as you can't hear or you can't see for some reason. We have staff available to address those issues or questions with you. Questions will be answered as time permits, and additional questions will be posted on the website following the webinar. So we're going to ask you to complete the post-webinar evaluation that you'll get about an hour after this webinar concludes. This helps us to improve future webinars and also gives us an opportunity for you to share your suggestions for future webinar topics. So we really appreciate it if you would complete that evaluation. So with that, let me take some time, just a minute, to introduce our moderator for today, and then turn it over to her. So the moderator for our webinar is Dr. Lori Kirstein. Dr. Kirstein is an attending breast surgeon at the Memorial Sloan Kettering Cancer Center, and she's also an associate professor at Cornell University Medical College in New Jersey. Dr. Kirstein, very pleased to have you be moderating the webinar today, so I'm going to let you take it away. Thank you.
Thank you so much. Welcome, everyone. So today's session is going to be about focusing on year 2 of Breaking Barriers. We're so glad that everybody could join us. I'd like to say it's going to be an earth-shattering webinar, but for those of us who live in the East Coast, it probably won't be as earth-shattering as what we felt this morning. All right, so next slide. Let me introduce our other panelists. Next slide. There we go. So Lauren Jancheski is a clinical scholar at the American College of Surgeons who's working on some of the quality improvement projects for us this year. She'll be sadly returning to her clinical residency soon, and we'll miss her. So she's going to give us a little update on what we collected from year 1 very briefly, and then she will be followed by me giving a little bit about what we're doing for year 2, and then finally we'll conclude with Sharon Gentry, who is the program director for the Academy of Oncology Nurse and Patient Navigators. She's the editor-in-chief for the Journal of Oncology Navigation and Survivorship, and the editor-in-chief for Conquer, the Journey Informed, and she's going to present a little bit on, well, actually a lot, on the role of navigation in overcoming barriers to care. Next slide. So again, our agenda, we'll review year 1 briefly, look ahead to year 2, and I'll be going over the timeline of what to expect in year 2, as well as an introduction to our new tech toolkit. And then Sharon will talk about leveraging navigation to address barriers, and we're going to leave a lot of time for questions and answers at the end, so please do post questions in the chat, okay? And then Sharon, if you want to turn off the video until your time, it actually saves bandwidth. So, okay, so with that, I'm going to introduce Lauren Jancheski. Lauren, why don't you give us a brief overview of what we found from year 1?
Thanks, Dr. Kirstein. We can head to the next slide. Next slide. And like Dr. Kirstein mentioned, this is going to be a fairly brief overview on what we found as far as our overall year 1 findings for those of you who participated in year 1. But just some brief background for those who are new to participating in year 2. We designed this project because disruptions in planned radiotherapy, specifically those who miss 3 or more radiation treatments, are associated with worse long-term oncologic outcomes for the patients. However, many of the reasons why patients miss multiple treatments are potentially modifiable barriers, such as psychosocial, geographic, or financial risk factors, which is why we sought out to design this project. And throughout the course of year 1, we had 342 accredited cancer programs across the country who enrolled and participated, and collected 5 separate, or conducted 5 separate data collection periods in this pre-intervention phase of the quality improvement project over the course of March through December of 2023 in a prospective fashion, where the programs identified patients who were scheduled for a 15 to 45-day course of curative intent radiotherapy, and then identifying those who missed 3 or more radiation treatments, like I mentioned, in order for us to calculate their quote unquote no-show rate over these individual data collection periods, as well as the specific reasons for why their patients missed treatments, which is aggregated hospital level or program level data only, not patient level data. But the bulk of what we found over the course of year 1, after combining all of these 5 separate data collection periods over the course of nearly an entire year, was that almost all of the programs that participated identified patients who missed 3 or more radiation treatments, and thus had patients who were potentially at risk for experiencing worse oncologic outcomes in the long run. By looking at the no-show rate, or the percentage of patients who missed 3 or more treatments at each individual program, we found that the median percentage was nearly 10%, which again means 1 out of every 10 patients at our accredited cancer programs were potentially at risk for worse outcomes, which amounted to more than 5,000 patients over the course of an entire year who did not complete radiotherapy as prescribed. We looked to see if there was differences between the different data collection periods, as well as the different types of cancer programs, such as academic versus community, and didn't see any statistically significant differences. But we did see differences based on the geographic region or location of the program, as well as disease site, where the programs located in the Northeast region of the country had the highest percentage or no-show rate, or percentage of patients who missed 3 or more treatments, at about 11%. And by disease site, we found that patients with rectal or gynecologic cancers were also the most at risk patients, whereas those with breast and prostate cancers were less likely to do so. Then when we looked at the specific reasons for missed treatments, this is at the hospital level. So what percentage of hospitals reported that they had patients who missed treatments for these specific reasons? We found that illness unrelated to treatment toxicity, transportation issues, conflicting appointments, as well as patients who no longer wish to pursue treatment were the most highly prevalent barriers, which for those of you who participated in year 1 will remember that we asked you to select potentially one of these barriers to address as a part of and select an intervention as a part of your year 2 participation, and partly what we're going to be talking about a little bit more throughout the rest of this webinar today. But overall, that's a brief overview of all of the hard work that those of you on the call who have participated in year 1, the findings from all of your hard work in data collection and participation in this project. And we look forward to hopefully reducing these rates by implementing these interventions from the toolkit with all of your participation throughout year 2. So overall, that's just a brief overview, again, like I mentioned, and I'm happy to answer any questions at the end, and I'll pass it back to Dr. Kirstein.
Thanks, Lauren. Thank you. And as Lauren said, we're all grateful for everybody who participated in year 1, and I'm so glad you're on the call today. Next slide. I'm going to talk a little bit about what to expect in year 2. Next slide again. So in year 2, what we're asking is for our programs to identify at least one barrier. I feel like we missed a slide. There was a slide on who's participating. Can you go back one slide? I'm so sorry. Or was this it? No, okay, next one. So we're going to ask our programs to identify at least one barrier from the ones that Lauren just mentioned, as well as others. So if there is a barrier that you feel or you have proven at your program is a greater barrier than any of the ones we have the top 4, please feel free to select that and just let us know about it. And you can also choose more than one barrier, so don't feel like you're limited. We'll ask every program to develop a problem statement and goal, and I'm going to go over that in a little bit more detail about what that means. we're asking you to implement an intervention from our toolkit. I'm going to introduce you to the toolkit, which will be available on our website, and you'll see how it's organized so that you can choose an intervention that you like. If you do find that there are other interventions that are more applicable or that are more effective for your program, again, it's okay to do that. We just have to define it and understand what that is, and you can put that in your data collection tools. We're again going to ask everybody to report data in regular intervals, and I'll give you that timeline later on. And this year, we're going to try to meet with some small group cohorts based on the barriers that you've chosen. So for example, if there are people who've chosen transportation as a barrier, we're going to try to get some small groups together to not only have content experts, but also to share best practices and problem solve with each other. Next slide. Oh, here it is. Okay, so of the 300 participants in year 2, 15% of you are new to the project this year, which means 85% are returning. That's terrific. 44% intend to address transportation as your barrier. 20% intend to address conflicting appointments. 16% will address patients who are sick unrelated to toxicity. And what that means is when you call the patient, they say, I just didn't feel well, but it wasn't that they were really sick. Probably. And then 11% intend to address why patients no longer wish to seek treatment. Next slide. So the first thing we're asking is for you to develop a problem statement. A problem statement is a brief statement on why your program's pursuing the project, and it should address who the problem affects, when it was found, and where it's happening, how often the problem is happening, what's happening that shouldn't be, and what didn't happen that should be. So as an example, one could imagine a problem statement would be, in our radiation department, our head and neck population was found to no show for at least 3 treatment appointments 70% of the time over the course of 6 months. And so something like that. So it's pretty specific. The SMART goal statement, so what are your goals? A SMART goal statement should be a statement on what you want to achieve over the course of time. So it should be specific and measurable, achievable, relevant, and timely. So the goal statement that would probably match that problem statement would be, for our head and neck radiation treatment patients, we would like to reduce our no-show rate from 70% to less than 50% over the next 6 months or over the course of this project. And so something that's measurable and achievable. When you're creating these statements, don't forget to consider limitations and stakeholder involvement. And so you want to think about, the radiation techs, the people who make the phone calls, the doctors who are involved in making the radiation plans, potentially the people who make appointments for patients. And we're going to ask you to report these in your June data collection. And so we're going to ask you to work on them. And I will say, if you're having difficulty creating either the problem statement or a SMART goal statement, please do reach out to us, email us, and we'll help you with that. Next slide. Okay, so the toolkit. The team at Breaking Barriers has developed a toolkit, mostly addressing the top 4 barriers, although we did combine 2 of them. So the illness unrelated to toxicity and no longer wishing to pursue treatment, really when we tried to look at interventions, the underlying issue was really psychosocial, and a lot of the interventions ended up being the same. So rather than repeating ourselves, we combined that section. So what you'll see in the Breaking Barriers toolkit is it's organized kind of like the example you see, barrier 1, transportation issues. What we'll have is an intervention and then some strategies to address the issue. And so, for example, if you're going to first identify transportation, if you want to identify transportation as the issue for your patients, one of the things you have to do is just ask, right? So why didn't you make it? Well, I couldn't get to treatment. How do you normally get to treatment? What were you planning? How were you planning on getting to treatment? Have you reached out to anybody? Just asking the patient. And that's a very simple intervention, but nonetheless, an example of one that our programs don't necessarily do. And what you'll see is that we've provided a lot of resources for addressing strategies. On the second example down, you'll see leverage ride shares and hospital-based transportation. And just looking down, you can see that we've offered multiple websites, medical transportation through Medicaid, Uber, Lyft health programs, additional transportation resources. And these are all links that are going to be available on the website. So we encourage our programs to log onto the website and just scroll through the toolkit to see what interventions might be applicable for your program. And certainly if there are others, please do share them with us. This is an interactive toolkit that we can update from time to time. And so it would be great to be able to add additional resources. Much like you did with the community scan, this is a very similar type project in which we want to keep it right, we want to keep it updated, we want to keep it timely, we want to make sure everything that's available is on the website. Next slide. The first data collection tool was sent out on Tuesday. It'll be due April 30th. It's really very basic. It's going to be your email, your FIN, hospital name, etc., sort of the identifying factors for your program. We're asking you to identify your barrier, and again, you can identify them by more than one if you like. And we want to collect data once again by disease site. So head and neck, colorectal, upper GI, GYN, breast, prostate, etc. And some of this should look pretty familiar to you. Next slide. This is the tentative timeline for year 2. We are in April already, as you can see. And so our first data collection tool will be due on April 30th. In May, we're planning on having a small group call. And again, we'd like to gather the data first to figure out who is addressing which barriers so that we can try to make the calls more helpful for you, so that you can do best practices, ask questions, get some content experts, etc. And you can see that this process will be repeated throughout the year. So June and July, August, September, October will be our last data collection period. It will be for the patients seen in August through September 30th. And that will be the end of Breaking Barriers. We will have a wrap-up webinar in December. We'd love to be able to not only give you back the information and feedback and what we learned from this project and learn from each other, but also to see how we could potentially look to upscale and keep the interventions more permanent within your institution, and we can have some problem-solving sessions. But we'll wrap it up in December. Next slide. And so with that, I will introduce Sharon Gantry, who's going to talk about the use of navigation in identifying barriers, but also in overcoming barriers. We know that navigation is one of the most critical parts to our patients as they have trouble getting through the system. And so Sharon, I'll turn it over to you.
Thank you. So excited to be here today and talk a little bit more on this about the oncology patient navigation. So if we can go to the next slide. Those of you that are able to use navigators, you can actually use them before they hit you in radiation oncology, but we're going to talk a little bit about that. But it's a professional responsibility and now one of our standards that any navigator, whether they're a clinical navigator or a patient navigator, that anytime that they are working with a process, a patient, an individual patient, that is part of their professional duty to look at your data collection, to analyze it, work with you on analytics, and reporting outcomes. So it's just not an added responsibility, it's something that you should be expecting from every one of your navigators that are in your program. Next slide. I want to make people aware that reason we're stressing right now the professional definition of navigation as well as the 3 types of professional navigators at this time. If you have navigators that are working on your project, they can at this time be able to get paid for their services with the release of the CMS codes for Medicare that happened in January 1st, 2024. But when we're writing things and addressing tools and such as you see in the toolkit, we'll identify 3 types of navigators. That's your oncology patient navigator, the one that does not have a clinical license. There's your clinical navigator, nurse navigator, and your clinical navigator, social work navigator. There are now professional standards that were created back in March of 2022 that tie into this reimbursement that a lot of you can use right now. So let's look at the next slide and look at one of the standards that you can use. This is standard 12 about treatment, care, planning, and intervention. That the oncology navigators provide support to the patients as well as information and also the caregiver through all phases of after cancer treatment. And you look here, the #1 thing is that all navigators identify potential and realized barriers to care. And you do see transportation here. I don't know, when you look at some of your barriers that you're dealing with here as well, they can't come to treatment or they call in sick and they may not be sick. Is it because of other issues going on, such as child care, elder care? Do you have some cultural and literacy issues with them? And I know you're always looking at the financial and insurance way before they get to you. But we do advocate for resources and support the necessary services to address these barriers. It'll be interesting sometimes when you're working on a barrier and you're thinking, we don't really have that resource there. And then you have to get real creative and say, how can you come up with resources? Or what is your #1 wish list to improve patient care in your environment? You can see that we've broken down into clinical nurse navigators, which have a little bit more role in the analytics of what's going on when they look at barriers. And then patient navigators, lots of times they'll work as a team member to the nurse navigator, and the physicians that they can answer or direct questions to about clinical information. So it's almost like a team approach when you're working with the different type of navigators around these standards. On the next slide, you'll see that a lot of your navigation starts before they even get to you in the treatment center. And when I looked at what some of those that tend to address this year, I looked at transportation. Transportation actually comes in down here at screening. Like, how did they get their transportation to screening, or was the screening delivered to them? And then how did they get through their biopsies or assessment, their staging, to even make it to this part of the treatment? So when you're looking at transportation, I'm hoping that you're looking at from a very wide systemic view, not just your department. But did this patient already have transportation issues documented in the medical record before they come to you? That's important, that you can look at these red flags before they get to you. The ones that are addressing your conflicting appointments, that becomes a systemic issue. Your whole system of care, you need to look at why are the conflicts there and how come this department is not talking to other departments. When you're trying to address someone that say they're sick, but it's not due to toxicity, is often, are we asking them the right questions? Is there a fear that they're facing? Is there another underlying problem going on in the home that we've not addressed that? And it's so critical sometimes that you call in your counselors and your social workers to help with you. For those that no longer wish to address treatment, intend to seek treatment at this time, I hope you've got some type of protocol that before you just totally say, okay, they're not coming to treatment, who do they talk to? Is there a counselor they talk to, a spiritual counselor, a social worker, a psychosocial counselor? Who do they talk to really get to what's the bottom of not wanting to continue treatment? So you can see, even though you're siloed in one of the treatment areas, that a lot of the things that navigators too can do, or the whole process of navigation, extends beyond of just the work there in the radiation oncology. So let me show you the next slide that we've come up with in 2024. And I hope a lot of you pursue this because you do a lot of work as navigators. There are now codes that can be used, the Centers of Medicare and Medicaid Services, for Principal Illness Navigation Services. There are 4 G codes that can be used. They can be caregiver training, telehealth, behavioral mental health science, but a lot of what we're doing is related to the patient navigation services. But there are things now that you can code for under the direction of a healthcare provider. If you're a patient navigator, you can use the G codes. Nurse navigators, social workers can use the clinical navigation codes. And we've also just been informed that we've got at least 40, I think it is 40, maybe less than that. Private insurance companies are going to come on with this too in 2024. So we're excited to see that it's just not going to be Medicare and Medicaid services, that private insurance say they're going to all start paying for patient navigation. So we're all learning how to do this since this was just released in January. So stay tuned, and I hope some of you participate to get your navigation services paid for. Next slide. I want to give you some examples of when you look at how can I show that what I'm doing is really the best, the return on investment that you can do. These are just 3 studies that can bring in financial support for your organization to address the needs of patients. The first one here was done years ago. You see it's dated 2011. But if you think about before they hit you in radiation oncology, hopefully someone's addressed them and kept them in the system of care. And this was just making the case for nurse navigators as someone did a gap analysis of why were the patients leaving the healthcare system. And that was probably even before they got to radiation oncology. So that's a great example that you can use if you're thinking, we're seeing people with this disease not even get to radiation oncology. Then the question is why? Another one is they used a nurse navigator, and they actually were able to educate the patients before they got into, this was a medical oncologist, but we could actually take this and say before they got into the radiation oncologist. And what they found out is by having a better educated patient coming in and talking to whatever physician it was at that time, it cut down on the time of that new patient visit. And under this practice, there were 4 medical oncologists. They reduced their new patient consult by 24 minutes by having pre-education on what to expect and what was going to be addressed that day. They actually saved around this, you saved $485,000, and they were able to add 1 new patient visit a day in the practice because of using nurse navigators. One of my favorites has always been this navigator no-show. Here on the side, on the right-hand side, this was actually patient navigators. It was not nurse navigators or social workers. They actually reduced no-shows in those receiving radiation therapy, and it equaled a navigator's annual salary because the overall return on investment was $5 for every $1 spent. And it's just little as much as they contacted, sometimes the high-risk patients 3 times a week to say, what's some barriers that you see, what's some problems. And so sometimes I think just those phone calls you can look at. A side note of this, they cut down the readmissions by 1/3 in emergency room visits using navigators. So there's 3 studies that you can look at if you're interested in involving your navigators with any type of metric that you're trying to use here as you break these barriers. Next slide, please. And you can see that navigators are more than barrier removal. When we did a survey nationally, we asked navigators, what do you mainly do? What is one of your primary job roles, responsibilities? And you can see this coordinating care was number 1. It's between the oncologist and the other physicians. And so that brought to mind those of you that are trying to address why are we having to address conflicting appointments? Your navigator can help with that. I think it was noted before that there's a lot of emotional psychosocial counseling that are needed with the patients. And even though your navigator might not have that psychosocial work, sometimes your patient's willing to share with them some things that they may not share with other physicians or whatever. Critical that that is shared with any physician or any healthcare provider before the patient's appointment, saying, this is their primary concern at this time. Let's address this and get it out of the way and remove that barrier before they get here. They do a lot of other referrals, and you can see down there is transportation and financial. But it's often, I want you to know that it's just more than that barrier removal. It's that support around the patient. It's that kind of interconnectivity between the care team members that your navigator does. Next slide, please. Okay. I think this opens it back up, or take it away to questions.
Thanks, Sharon. I think that we all know and we all appreciate how important nurse navigation and all navigators are to our patients and to our systems, and just to the programs out there that don't have a navigator or have difficulty with navigation in their system. You know, there are multiple ways to help patients navigate through the system, and there isn't one right answer, but that the crucial point is to understand that there are lots of barriers that exist throughout the patient's journey, and that sometimes it's going to be somebody who's not the physician who actually helps the patient to get to their final goals. And so with that, I want to open up questions for year 2. I know that Eileen Riley, who is our lead for this project, has been collecting these questions and answering some of them. I'll throw out the first one that she assigned to me, and then she can bring some others to the group. The first one was, do we need to use standard 7.3 template to report on breaking barriers for this year in year 2, and it was not used for year 1? And the answer is no, we are not requiring you to complete a 7.3 template for year 2 either. So Eileen, do you want to put out some questions that we received?
Yeah, absolutely. So we have a few more. One of them, I'd love to hear, Dr. Kirstein and Dr. Jancheski, what you think. Do you have to have separate problem statements and goal statements for each barrier chosen if more than one is chosen?
Lauren, do you want to field that one first?
Sure. That's a good question. And Dr. Kirstein, feel free to chime in if you feel otherwise. But I think if you're choosing two separate barriers because you're experiencing patients who miss treatments due to separate reasons, then it might be helpful for you to have two separate problem statements. However, I could also see the case for having one if there's a fair amount of overlap between the two. So I don't know if you feel more strongly about one versus the other, Dr. Kirstein.
Yeah, I mean, I don't think it's a requirement. I think your point, which is if there really are two problems, let's say, that you're having with your patients getting their care, so transportation and conflicting appointments, I think it's really helpful to write two different problem statements only so that you can, in your own mind and with your team, clearly understand what you are trying, why it's that, and what you noticed, why you noticed that was one of the barriers, and to develop a goal specific to it. I think if you want to write an overarching statement that says something like, we notice that our patients are, 20% of our radon patients in GYN are missing their appointments over the course of time, and we want to reduce that by 70% as a goal, that's good. But again, the point of this project, A, is to help our patients get back to care, but it's also to help you guys learn how to do a QI project and how to understand what the fundamental foundations of a QI project are. And so writing a problem statement and a SMART goal statement with one specific problem in mind might just help you define it better. So is it required? No. Would it be helpful? Yes. Eileen, what do you think?
Yeah, no, I agree. The other thing I want to caution, though, again, sometimes we feel like we have to do everything for this to be, like, look how much we're doing QI so great. And it's not about how much you're doing or how much you're addressing, but just kind of how thoughtful you are in addressing. So I know that wasn't really the question. One problem statement, two problem statements. I think two would make sense. Especially just kind of based on how nuanced your different problems are. And it's a good question. We'll leave space in the next data collection tool if you wanted to write two problem statements. You don't have to, though. Again, I want to encourage you to not bite off so much that by the end of this 1-year project, which really isn't a lot of time, that you still feel like you were able to accomplish and make progress somewhere. And then just to reiterate that is due June 30th. It'll be on the next REDCap data collection. We'll have just a paragraph of space for you to write, just a little bit about your problem statement and your aim statement. So June 30th will be when that's due. Another good question I got, our barrier didn't fall in any of the 4 listed categories. Will you still have a small group for us? And I would like to say yes. Dr. Kirstein, what do you think?
Yeah, I mean, absolutely. I think we'll have to figure out what to do with people whose barrier doesn't fall within the 4 and figure out if there are any interventions that are similar that could be applicable, or if we can put another group together of people whose barriers fall outside of the 4, or if there are a few in a particular category. I mean, the truth is we would love to be able to put people together within this project as part of the collaborative. And, we went through the data and we categorized these as the top 4, but that doesn't mean that it's going to cover everything, and we know that. And so this is not a written in stone, we're not rigid here. So we would love to be able to make as many small groups as necessary and to help people and connect people throughout this project.
Great. Agreed. Dr. Jancheski, a question for you. I'd like to hear your thoughts. Can we change the disease site in year 2 that we were reporting on? Can you talk about kind of the data collection strategy and whether to kind of change it or keep it the same as you did if you were participating in year 1?
That's another good question. I mean, from the criteria that we set from the beginning, was that the programs, for each data collection period, you are able, and Eileen or Dr. Kirstein, correct me if I'm wrong on this, but for each data collection period, programs have the option to submit multiple disease sites, and which disease sites you choose is up to you. So if you feel like you need to change disease sites, I think that's up to the individual program for what you, compared to what you were previously have been submitting. However, I think if you're able to keep it consistent in most cases, that'll provide us with the most accurate comparison in the pre to post intervention phases after we after you have access to the toolkit and start implementing the interventions that we've put together to be available for you, just so that, especially for your individual program, it'll give you a more accurate comparison to see whether the interventions that you've worked on implementing have helped reduce the overall no-show rate. So long story short, I think if you're able to keep it the same, it's up to you, but really it's, or if you're able to keep it the same, that would be probably better and preferred. But if you, it's not a stringent guideline if you do need to change which disease site you choose to report on.
Yeah, what I would add to that is, so last year, if you only reported on one disease site, because that's where the bulk of your no-shows were, then clearly in year 2, it would be good to report on that disease site so you can measure your change, which is what Lauren was saying. But let's say, 2 to 3 months in, you notice that you're doing a really good job and that you feel like you want to add another disease site to the mix. We would ask you then to continue to collect your primary disease site that you implemented from year 1 and add to it. And likewise, if you have 2 or 3 different disease sites that you noted in year 1 that were having issues and you focus on one first, but you need to pivot to another one, we would again say, keep collecting the one that you're pivoting from while you add on. So that way we can still collect all of that data. I mean, part of the goal of the project is to be able to take this information that you've collected on why your patients aren't showing up and then figuring out how to fix it and then scaling it up to others. And so if that happens in year 2, that's wonderful, but we do want to have some consistent data just so we can, look at it over the course of the 2-year project. Eileen, what do you think?
Yeah, no, agreed. If you can keep it the same, please do. That way you're comparing apples to apples, especially over 2 years. To be able to compare over 2 years is really valuable data. So do try to do that. You could always add on, but try to keep it as consistent as possible, I think would be a way for you to make sure that not only are you making changes, but those changes are being sustained over time. Because oftentimes when we start something new, what we previously did might kind of regress back towards the mean. And so for sustainability purposes, I think it's smart to continue to submit the data. A question, I can answer this one. Are you able to provide our individual facilities with summary of data submitted in year 1? I would love to be able to do that. Unfortunately, we just don't have the capacity to send 300 plus individual reports to each of you. We recognize REDCap and its ability to kind of collect this quality improvement data. It has its limitations. We're only 2 years into our national projects and still kind of trying to figure out the best database and platform and tools to be able to do this work. So we encourage you to keep copies of the data that you submitted so that you can look at it. We can't send 300 reports multiple times a year to everybody. That would just be a little burdensome for the staff here. A question, the wording on the REDCap has our team confused. We developed symptom protocols for a variety of cancer-related symptoms. Is this still patient sick, not due to toxicity? Dr. Kirstein, what do you think?
Well, when you say, I would say that toxicity, patient not showing up for toxicity related to treatment means that from radiation treatment, they were burned, or if they're doing concurrent chemotherapy, they had to be admitted to the hospital for whatever reason, neutropenia, fever, etc. And if those are what the symptoms that you have developed and they're all related to the treatment, then it doesn't fall into toxicity unrelated, or illness unrelated to treatment. If you have a reason. And in truth, if somebody had COVID or they had the flu or something and it was documented, then yes, it's unrelated to treatment, but it's sort of documented illness. What we're really trying to collect is when you call the patient and the patient, why didn't you come? I just wasn't feeling well. I just wasn't feeling great. And you can, dive into it a little bit more of, well, did you have a fever? Was it this? Get a little more information about it. What we have found is that some of the patients will just use I didn't feel well as an excuse, and that there's actually something else going on. And so symptoms are great to collect, and it can help identify patients who are having symptoms related to treatment. Or if patients really are sick, that's okay. But what we're really trying to get at is sort of the psychosocial reasons why patients aren't showing and just saying, I didn't feel well. Does that help?
Let us know if it helps.
Yeah, I don't know if that answered your question. I think that what we were asking is for people to just do a deeper dive when the patient said, I didn't feel well. And some patients don't feel well. They're getting cancer treatments, but some patients aren't showing up because they don't want to come for other reasons. And I think that's what we're just trying to tease in between.
Great. A quick question. This project qualifies for NAPBC credit, correct? Yes, if you're participating, you're either participating for COC credit or NAPBC credit. You do not get both, but also if you're participating for kind of that NAPBC credit, you're obviously reporting your breast patients. That's the disease site you're focusing on. So just want to plug that. Here's a great question, and I'm trying to see, I don't think Dr. Shelton's on because he's been so helpful in getting us data. I wonder if Dr. Hafty's on, but can you provide us a few studies showing the impact of missing treatments to survival? Our physician doesn't discourage a patient missing if they have something else to attend. I'll take a quick look. I think in our at-a-glance details, we do cite a few articles, but Dr. Kirstein or Dr. Jancheski or Sharon, I don't know if you guys have articles you can reference, or we can probably post some things to the website that really kind of highlight why this is important. But any thoughts there?
Yeah, so I mean, Dr. Shelton does have them. They might even actually be on our website already, but there are some, especially with head and neck cancers, there are some good published articles and data to show that missing 3 radiation treatment appointments for head and neck radiation patients had an impact on local regional recurrence rates. And sometimes the local regional recurrence can impact survival as well, overall survival. And so we have that one. There's less available for things like breast and prostate, obviously. But for the more aggressive tumors in which they need to be sort of radiated quickly, I mean, I don't know if there's anything for pancreatic or HPV out there, but definitely for head and neck cancers, there's excellent data to show that missing 3 or more appointments impacts local regional recurrence rates. We can find them and put them on the website if they're not already there.
Yes, thank you.
Dr. Jancheski, you did a little bit of a lit search, I think, on this.
Yeah, I have some more articles that maybe I'll share with Eileen, and then we can make them more readily available for the participating programs.
Oh, and just to put it out there, in addition to our toolkit that we developed for breaking barriers for these barriers, we're also going to be linking toolkits from the COC that were developed on financial toxicity and health literacy, because those may be issues for your patients. And if you're talking about health literacy and why it's important to show up to help your patients understand why it's important to show up for treatment, the articles that we'll post will probably be most applicable for health literacy, if I had to guess. So just those will be available too, once they're available to us.
Okay, perfect. A few quick questions here for you. You just received a link to complete your data that's due by April 30th. The collection period for that is February 1st through March 30th. So those are the patients and missed appointments you're looking at. It's February 1st, 2024 through March 30th, 2024, patients seen for treatment in that time frame. Have I been assigned a small group yet? No, you haven't been assigned a small group yet because we need to know your barrier, because we want to kind of cohort you based on what barrier you're working on. So on the data collection tool that you submit April 30th, we're kind of making you choose a barrier. Up until then, we've kind of given you an option to say, well, I'm not too sure. But now we took away the unsure option. You have to pick a barrier. And from there, we'll kind of cohort you into smaller groups. If you have a question, you can email cancerqi@fax.org. What if a small number of patients that missed in one category can be addressed, but it will not affect the masses? Will that count, Dr. Kirstein?
Oh my goodness. These are very specific questions.
Yeah.
So what I would say, so if you can address a barrier that addresses sort of a small group of patients, but not a larger group of patients, is that what you, okay, so if you have a barrier and you fix that barrier, if overcome that barrier for a small group, I would encourage you then to address the larger group. I mean, I think, does it count? Look, you know, there's no police here that's gonna, you know, go through your stuff and say, you didn't do this or you didn't do that. What we're really looking for is a good faith effort. And so just as an example, if you in your program report that you have 100 patients who no-show and you pick a barrier that only addresses 3, it's really a great faith effort. If you say, I'm going to do it with the 3, and if I'm successful, I'm going to try to roll this out to 50 more, that's successful to us. I mean, I think there just has to be, you know, there has to be some sort of effort there to try to help your patients overcome their barriers. The more, the better. And granted, we're not asking you to say, I'm going to address something that has to, you know, there's not one size fits all for everybody. But I think that we would like you to try to address as much as possible over the course of the year. And so if you choose a very tiny population and you address it pretty quickly, then the question becomes, what are you doing with the rest of the year? So what do you think, Eileen?
Yeah, I think what you said. I think we might need more context though. So the person who asked that question, if you're able to either put in the chat box here more context to that question, because I'm interpreting it the way you did, Dr. Kirstein, and I hope we're interpreting it correctly. Or again, email cancerqi at fax.org with kind of more detail, and we'll be able to give you a more kind of detailed answer. Must we choose a recommended implementation initiative, or can we pick one that we feel would work not from the examples listed? So I think this is, do we have to choose something from that toolkit, or can we choose something else?
You can choose something else.
Yeah.
I think that the goal of this project is to walk you through a QI project in which you identify a barrier, and if there are different methods in your own system or in your area or whatever you find that is more successful than anything we have posted, that's great. Share them with us. I think more so than anything. You know, again, this isn't meant to be rigid. This is meant to be a foundation. And if you need the foundation and you want to walk through the foundation as the project for your institution, that's completely fine. But again, you don't have to. You can jump off at any point to figure out what works better for you. And you know, one of the nice things about this project is hearing about what each of the different institutions are doing and sharing best practices, because I really do think that we learn from each other even more so than, you know, the group of us sitting in a room trying to figure this out. And so if you don't have to use the toolkit at all, we would ask that when you fill out your data collection form, you just identify and define what you're doing, and that's fine.
Agreed. And that leads into kind of another question, which is the first data submission will be without intervention, correct? And yes, we, you know, these first 3 months of the year here, especially for the newer projects, but obviously if you've been working on this for a while, you didn't necessarily have to do kind of any implementation at this point in time, although we will say now here we are in Q2, you are looking at that toolkit or kind of looking at your community scan, identifying those interventions, and then now you're implementing them, right? But this past data collection is still kind of that baseline area where you're not necessarily implementing. So yeah. And then another question, I like this question. Will this study ever look retrospectively at the patients in our cohort to see if there's correlation with things like age, annual income, how many cars in the household, et cetera, to identify risk factors? That sounds like an awesome research project. However, not a quality improvement project. So that's what I would say. But Dr. Kirstein, I don't know if you have other thoughts on that.
Yeah, so I agree. I mean, listen, I think that one of the limitations of doing these national QI projects is that we don't have any identified data, right? So we don't collect information about the patients, anything, nothing, right? So no age, we don't know anything except what disease site and sort of your area of the country is probably the best we can do, and what type of program you're from, right? So academic, community-based, et cetera. But we don't have any patient identifying information. And as frustrating as you think that is for you, I think we also feel incredibly frustrated. You know, when we set out to create this project, we really very strongly wanted to collect some data on social determinants of health, and it just became very difficult and impossible to do. And we really can't do anything that is either program identifying or patient identifying. So that is a major limitation, and it's frustrating for all of us, to be honest with you. If you want to do it within your own institution, I think it's fantastic. Certainly there's some information in the NCDB on social determinants of health, not tons, but, you know, ethnicity, et cetera. And I don't know how we couldn't ever use that data and then identify our programs. We're not allowed to do that. So it's really, you guys are on some level, the research project is with the programs, and the programs are the subjects. So it's actually protecting your patient, you know, your PHI, so to speak, your program health information or your program identifiers. We're just not allowed to do it. It's a shame.
Yep. And then here's a great question I think we'll probably need to talk about a little more, but if a barrier wasn't identified other than treatment toxicity, which we know that was a huge barrier for folks, is there a way to still participate in year 2? For example, we want to improve the process of documenting or keeping track of missed appointments. Can we use that kind of as our barrier if we don't fall into one of those other categories that were identified or rose to the top?
I would say yes. I mean, what I would say is in year 1, if you were able to identify that toxicity was a major barrier, so there are a couple of things I'll say about it. One is we'd love you to participate, because if you're doing things like transportation and conflicting appointments well, we would love to, if you wouldn't mind identifying yourselves to us, we can hopefully hook you up into different small groups where you could be best practices and teach other people and share what you're doing that's so successful. And 2 is, if patient toxicity is a barrier why they're not showing up, you know, we did not delve into this because it's just too much. However, if that's the major impediment to your patient showing up, to look and see within your own institution if there are supportive services that can help with patients who aren't able to make it to treatment because of toxicity. And that maybe a navigator would be also a very good tool, because you know, if patients, you know, for us, it's like there's wound clinic, you know, wound care clinic, just different supportive services, hydration services, et cetera, for patients. And just to make sure that if toxicity is your barrier, that there are systems within your own institution that address some of the problems with toxicity to prevent the patients from getting treatment. I mean, ultimately, we want our patients to get their treatment. And I think if we can help them get that, that's the best thing of all. And so you don't have to do that. That's not a requirement. And certainly we're not defining that as part of our toolkit. But just as a clinician, I would say that that if that's what's really stopping your patients from getting to treatment, just make sure you have the supportive services available. And perhaps that's how you could do it at your own institution this year. But yeah, we would love you to participate. I mean, not everybody's going to have major no-show rates. And whatever small rates you have, hopefully we can help it, but also that you can help other programs.
Great. Here is a program. They participated in year 1 and submitted head and neck, breast, and GYN. Do we need to choose only one site?
No.
No. Yeah, no.
You can do all of them, whatever you want. I mean, you can take one intervention and apply it to multiple treatment sites. You can take one disease site and apply multiple interventions. You can do multiple to multiple. It's really up to you. It's very flexible.
Yep, agreed. But again, we just ask that you be consistent. So if you are submitting 3 sites this time, please submit those same 3 sites over the course of the year. Again, just so you can compare apples to apples within your own kind of program. But no, you don't need to choose one site. It looks like the questions are slowing, and we answered, I think, most every one of them. But again, if you do have a question, feel free to put it in the chat box. I encourage you to reach out to cancerqi@fax.org or view our project website for a lot of great resources there. And Dr. Kirstein wanted to see if you have any kind of final thoughts or words to leave us with.
Yeah, just to say we're so excited that there are 300 programs participating again this year. If there are programs that did not participate in year one and you have questions about data collection or anything, to catch you up to speed for year two, please do reach out. We Eileen Riley and Tashay Coates, who are the two admins for this project, are just knowledgeable and helpful. We all want to get you through. And remember, it's all about the effort. It isn't, nobody's grading you here, but we're so grateful on so many levels for your participation, not only for cancer programs, but for your patients and for your communities. So we look forward to collecting your data and just seeing how things improve over the course of the year and to letting you know how you're all doing. So thanks so much. Don't forget to fill out, if we have a feedback survey, to fill out the feedback survey. Again, you'll look out for the data collection period, which will end April 30th. And we look forward to reaching out to you to get you into some small groups.
Thank you.
Thanks.